Good morning, everyone. Myself, Dr. Vandana Thorawade. I am Associate Professor, presenting unusual swallowed foreign body which we encountered with unusual presentation. One may encounter during their PG or being a consultant, many foreign bodies. Commonest seen are coins, bones, mutton, chicken pieces, etc. This study aimed at to study different symptoms on presentation of an accidentally ingested foreign body in 14-month-old baby, to study common age group affected, to study different symptoms on presentation, and to study the importance of thorough examination of aerodigestive tract. This was a 14-month-old male child, a small baby of a farmer family. The baby developed sudden onset difficulty in breathing while eating biscuit and something which nobody witnessed. But there was no history. When the baby attended, there was no history of cough, fever, URTI or change in voice. Baby was taken to some local doctor there. What was done, kind of intervention in OT, that was not disclosed to the patient's relatives. But the patient was referred to us, and when examined in casualty, baby was conscious, drowsy, irritable, tachypneic. All the respiratory muscles, accessory muscles were in action. Intercostal indrawing was there, suprasternal retraction was there, and on the respiratory system examination there were bilateral crypts, reduced air entry in bilateral upper lobes. So we suspected maybe acute epiglottitis or maybe possibility of foreign body or croup. Video is not playing. This was the presentation. So looking at this presentation, anybody will definitely suspect of which is of sudden onset, definitely, while eating something, biscuits. So anybody will think of a foreign body aspiration, possibly. We advised chest X-ray, which was normal. So to confirm what may be the possible cause, we advised CT thorax, which showed a soft tissue density structure 5 mm in laryngopharynx on the right side. They put a probable diagnosis of hematoma. Considering previous intervention, details were not available. Another soft tissue density of size 1.4 mm was seen in right main bronchus, where they put a diagnosis, possibility of a foreign body or inspissated secretion. There were patchy areas of consolidation in upper lobe on the right side and left lower lobe. Blood investigations being normal. Very next day, we took the patient in OT for check bronchoscopy under general anesthesia. Rigid pediatric ventilating bronchoscope of 3.5 mm was introduced under vision. During introduction, as you know, we get to see laryngopharynx. Laryngopharynx, we felt probably hematoma, considering the CT scan report which was given, into right pyriform fossa. So the important being stridor as a presentation, it was mandatory for us to visualize laryngotracheobronchial tree first and to take care of whatever is there in the pyriform fossa later on. So we negotiated the scope below the cords. There was subglottic edema. There was pus in the trachea as well as into right and left principal bronchi. Crust was removed. But I felt personally that this may not be the cause for such inspiratory stridor. So we withdrew the scope, we take out the scope from laryngotracheobronchial tree and requested the anesthesia resident and lecturer to intubate the baby with 3.5 mm ETT. And now bronchoscope was removed and pediatric drill scope was introduced to visualize thoroughly laryngopharynx. When the suction was put around this hematoma, it was like hard feeling structure, totally impacted. It was not getting sucked out. What was suspicious as per CT scan was not correlating at all. See what we got. With a lot of difficulty, we could also isolate this foreign body, very unexpected, a thorny seed, totally impacted into right pyriform fossa mucosa. Difficult to separate it from surrounding mucosa. This is a grass we get to see by roadside, and farmers might be getting to see everywhere around. So this was not witnessed during baby was eating biscuits. Discussion part. This is a slide I got from Indian Journal. These were the attempts in historical area to remove foreign body in ear, foreign body ingested or inhaled. That doesn't carry any importance nowadays. We know in 18th century, Sir Chevalier Jackson, who is called as father of bronchoesophagology, he developed distally illuminated scopes. He developed an art of foreign body removal from air and food passages. He improved the instruments and brought it to the present state of perfection. He made our profession foreign body conscious. Commonly ingested foreign bodies gets lodged into oral cavity, oropharynx, piriform fossa, posterior pharyngeal wall, commonest site being postcricoid area, and natural constrictions in the esophagus. Commonly affected age group is age less than 10 years, sometimes in psychologically disturbed patients, and likely possibility in the adults who are under the influence of alcohol. Presenting symptoms most commonly pain, difficulty during swallowing, drooling of saliva, anorexia, hematemesis rarely, failure to thrive where any child specialist or ENT surgeon may miss to take a chest X-ray and baby might be brought repeatedly with chest infection and failure to thrive. And if we get a chest X-ray done, one may come across long-standing foreign body which is lost, which was not witnessed and which was definitive diagnosis could not be done for longer duration. Similarly, Jackson and Jackson has mentioned similar foreign body which was traced after 15 years. It was reported in 1936. Such long-standing foreign bodies can lead to aortic aneurysm, esophageal strictures, neck and mediastinal abscesses. A sharp foreign body might keep on migrating into the neck, into the thyroid, great vessels, heart and lung, leading to disasters. To conclude, foreign body in the aerodigestive tract are common in children and psychologically disturbed persons. Commonest site being cricopharynx. Radiolucent foreign bodies are difficulty during diagnosis. Troublesome foreign bodies are impacted, sharp, long-standing foreign bodies or forgotten foreign bodies. Parents of mentally retarded children or new parents, please don't neglect the change in behavior or change in dietary habits in your child. Earliest intervention by expert surgeon and expert anesthesiologist gives a favorable outcome. This case is presented over here being unusual presentation and unusual to tackle with. So, budding ENT surgeon, they must keep an habit of thorough ENT examination, and beyond that, aerodigestive tract whenever a foreign body ingestion or inhalation is suspected. If one puts anything in the mouth, if one puts into his mouth nothing but food in a proper form for proper age, foreign body accidents would be definitely rare. Thank you. These are certain references. Thank you, sir.
Now I request Dr. Deepak Sawalake sir to hand over the certificate to Dr. Vandana Thorawade.